So hello and good morning, good afternoon, or good evening to each one of you, and welcome. I'm Sarah Dillard, an engagement officer at IHME, and I will be your facilitator today. Thank you so much for joining us for this session, GBD 2023, a closer look at demographics. We can change this slide. All right. This is the fourth topic in our GBD 2023 in Focus series, in which we provide an overview of the GBD 2023 results, followed by an in-depth look at each of the three capstone publications for this round of the GBD. So that one right there, November 3rd, of course, we're on this call right now. And then we also have another offering of the same session on Thursday, or on November 6th. And in between, we have a non-fatal and risk factors session on November 5th. And we'll come back to this at the end as well. But we hope you can join us for those if you're interested too. And we can change to the next slides. So today we have the distinct honor of having Dr. Austin Schumacher as our presenter. And I'll start things off today by telling you a little bit more about him. And afterwards, I'll share some more information about our program today before Dr. Schumacher begins his presentation. So Austin Schumacher, PhD, is an assistant professor of health metric sciences at the Institute for Health Metrics and Evaluation, or IHME, at the University of Washington. He leads the Population Fertility and Mortality Research Team, an outstanding group of researchers and staff that develops methodology and produces estimates for the demographic components of the Global Burden of Disease Study, or GBD. His own research interests focus on developing statistical methods and modeling frameworks to improve estimation of demographic and health indicators on both local and global scales, and subsequently utilizing this research to increase understanding and ultimately improve health and well-being. He specializes in Bayesian methods, small area estimation, and general techniques for biostatistics and data science. Before joining the faculty at IHME, Dr. Schumacher received his PhD in biostatistics from the University of Washington. And during his graduate research, he worked on many projects relating to statistical methods development for global health problems, such as age and cause-specific child mortality estimation, joint small area estimation models for multiple outcomes, and analysis of complex survey data. Prior to his PhD, Dr. Schumacher was a post-bachelor fellow at IHME on the team that he now leads. And we can go to the next slide. So before Dr. Schumacher begins his presentation, I want to briefly review our agenda and go over some logistical items. So during today's session, we will spend approximately 30 minutes exploring the critical findings across all three of the capstones, and afterward, we will proceed to a 20-minute question and answer segment. Out of necessity, mics are muted, and we invite you to ask questions today using the Q&A function that you should see on your screen right now. And you're welcome to add questions at any time during the presentation, and we look forward to addressing those questions. Lastly, we are happy to confirm that this presentation will be recorded, and we'll share it with all collaborators, including all of you who are on the call today. And with that, I am happy to invite Dr. Schumacher to take the stage.
Great. Thank you so much, Sarah, for the wonderful introduction, and hello to everyone and welcome wherever you are in the world. It's great to have you here, and I'm excited to share a little bit more about the methods and the results for the demographic research, particularly all-cause mortality for the GBD 2023 round of estimation. So I'll get started. First, just to give you some details, in case you missed it, we published the Global Burden of Disease Study 2023 results on October 12th. And in particular, the capstone publication that we'll be reviewing today is the one presented here on age and sex-specific all-cause mortality and life expectancy estimates. So this produced updated estimates of age-specific mortality rates and life expectancy for this round of the GBD. And some highlights are that includes data that we've never before used in the global burden of disease. And it also introduces a new novel method for estimating age-specific mortality. Some of the important highlights in particular in terms of the results discuss the COVID-19 pandemic period and the post-pandemic recovery period and various impacts that the pandemic has had and how recovery is going across the globe. So we'll dive into all of this in a little bit more detail now. So for the data updates for the all-cause mortality estimation for GBD 2023, one of the most important ones is that we have extended the age ranges that we've used data from complete birth histories. So complete birth histories are a very important source of data for child mortality in countries that do not have adequate vital registration systems. And they allow estimation of mortality by asking women respondents to surveys about the full birth history that they've had and whether their children are alive or dead and what time they died if they did. And previously in GBD, we've used complete birth history data to just collect data on the aggregate 0 to 4 age group, so for all children under 5. And this data, there's no restriction to just limiting to the under 5 age group, because all the complete birth history of a woman is asked about. And so we attempted to extend this data to more age groups into the ages 5 to 24 range, and we ended up including data on ages 5 to 9 and 10 to 14 years. For ages 15 to 19 and 20 to 24 years, we did not end up using this data because we noticed a consistent downward bias in this data, as well as a large amount of variability in this data. So we felt that data in these ages were not adequately reliable to use. But this allowed us to use data in these in the 5 to 14 age group. And what we've seen, which we'll get into more in the results, is that when the data that we actually observe in these ages show mortality to be a lot higher than we had previously estimated, especially across sub-Saharan Africa. So this is a very important source of data to include in this round of the GBD. Additionally, we reassessed our use of sibling survival history data. So this is data where respondents to a survey are asked about the mortality experience of their siblings, whether their siblings are alive or dead, and what ages they are. And we had previously used an aggregate age group of 15 to 59 in previous rounds of the GBD, and analyzed the data with specific corrections relating to these ages. But we wanted to try to get more granular detail from these data sources as well. So for this round, we calculated mortality in 5-year age groups from 15 to 19 through 45 to 49. We also looked at ages 50 to 54 and 55 to 59, but similar to the complete birth history data in older age groups, we saw that this data had a consistent downward bias, and also data was very sparse and had a lot of variability. So this data was also deemed not reliable to use in these age groups. So we particularly focused on ages 15 to 49. And this allowed us to get more granular age detail from these age groups that we had not previously used in the GBD. Furthermore, we incorporated data from health and demographic surveillance sites. And so we have had 38 locations of this health and demographic surveillance site data, which essentially is a complete VR system for a very small population within a country. And this allows us to get a lot more detail about age patterns of mortality in low and middle income countries, particularly in sub-Saharan Africa. And while it's not nationally representative, it allows us to see what age patterns of mortality look like. And this data was very important to include to get a better understanding of mortality in these low-income countries. And in addition to this, we used household death recall data, which we had been previously using, but we reassessed the plausibility and usability of this data across all of the available data that we had. So household death recall data is from censuses or surveys where households are asked about any deaths that happened in the last year or the last 5 years or something like that. And so by reassessing this data, it allowed us to get more accurate information about age-specific mortality rates in places that do not have good vital registration data. And I'll take an aside here to say that the reason that we were able to use this additional data for complete birth histories, sibling survival histories, health and demographic surveillance sites is because of our new statistical model that we developed that I'll talk about shortly. It allowed us to use data at these finer age granularities and these extended age groups, and also this non-representative HDSS data or non-nationally representative HDSS data in ways that our previous methods did not allow. So that's the main innovation here that allowed us to use this additional data. And finally, when we look at vital registration data and sample registration data, we had previously only been able to use officially released data that came with specific age granularity available and sex granularity available. But again, with our new method, our new statistical modeling method, we were able to use more aggregated data. And in particular, we could use provisional data that had been released that only reported total deaths and did not report deaths by age. And so this provisional data had never before been used in the GBD, but our new method allowed us to incorporate this all age provisional data in order to get the most up-to-date data possible and make sure that our GBD estimates are as up-to-date as possible. So previously, for the global burden of disease study, we had sort of a piecewise modeling procedure in order to produce all-cause mortality by age and by sex. So this procedure, in short, was that we had one model for child mortality, and we had a separate model for adult mortality. And these two models used all of the available data, but they were fit separately, and they produced estimates of child and adult mortality for all locations in the GBD. And then after we had these separate estimates of child and adult mortality, we put them together and use them as inputs into what's called a model life table system, which is a demographic method that is very commonly used. It's used across other sources of estimates, such as the United Nations and the WHO. And model life table systems are a way of estimating a complete age schedule of mortality using a small number of inputs. In this case, we use child and adult mortality as inputs. And then after this, there were some post hoc adjustments for HIV and also the COVID-19 pandemic. And this is what the simplified version of our method. However, this method sort of became this very large, complicated process that involved a lot of separate data processing steps to produce various inputs for all of the different models, for the child mortality model, the adult mortality model, and also some other subsequent models such as age sex splitting of child mortality and things like that. The creation of our empirical life table database and then the model life table system, the steps for incorporating HIV, also adjusting for COVID-19 excess mortality. And we had this ballooned into this large unwieldy process that was very complex, took a lot of time to run, had a lot of pressure points in this system that or in this process that errors could be introduced. And we wanted to create something that was more robust, simpler, more streamlined, and therefore would yield more accurate, more timely estimation. In particular, the model life table system that was used, these model life table systems are, we feel, a bit outdated. The issue is that, well, basically it takes a small number of input parameters. Like in our case, we use child mortality and adult mortality as inputs. And then these inputs are used to match to known life tables. So for countries that we have accurate data for, which tend to be higher income countries, and a lot of lower income countries are not represented in these empirical life tables that get matched to, then we use the age patterns in these observed life tables and impose them onto locations that we don't have age-specific mortality data, and we only have these estimates of child and adult mortality. And so that's essentially how the age schedule of mortality was created in these model life table systems. And it has the unfortunate consequence of imposing age patterns of mortality on populations that may not match those that are actually in these known life tables. And so rather than do this, we wanted to come up with something that we could use data directly to inform the levels and the trends in mortality rates across age. So that's generally what the goal was for GBD 2023, was that we wanted to radically simplify and improve our all-cause mortality estimation process. So we didn't want to have separate models across the process. We wanted to have a single model that we could use to directly model mortality in GBD age groups using the data directly. And then we also wanted to remove the special treatment of HIV and COVID-19 in order to come up with a process that's as a whole encompassing of all of this all-cause mortality estimation. And so the general idea is that these model life table methods were essentially a way of estimating correlations across age-specific mortality rates, while the child and adult mortality inputs, so these modeled inputs that we created, are essentially estimates of the levels of mortality. And so rather than having all of these separate models to estimate levels of mortality and correlations across age, we wanted to estimate these levels of mortality and the covariance structures via a single model using the data directly. And at IHME, we've developed a statistical modeling tool called OneMod that is a single statistical model that incorporates parametric and non-parametric methods in order to estimate a single parameter across a number of dimensions of inputs. So this OneMod model that we used for all-cause mortality estimation, it involved these three main components of it. The first is the spatiotemporal modeling component, which used very flexible splines and also incorporated covariates, which are known drivers of all-cause mortality. And it allows for correlation structures across age groups, and these correlations can be specified with spatial structure. And we also have temporal trends, which are correlated, that also have nested spatial structure as well. And this flexibility is very useful in order to borrow strength across time, across space, across age, across covariates, in order to produce as accurate of estimates as possible. So that's sort of the first step, which is this produces this what we kind of think of as like a backbone of estimates for all-cause mortality. But we want to try to get as much information from the data as possible. And in places where we think we have really, really accurate data, a spatiotemporal smoothing model might smooth away too much of the signal from that data. So we want to try to extract as much of that as possible. And so the next step is what does that, which is this kernel regression step, which is a non-parametric regression that is used to fit data well in places that we trust the data a lot, and then in places that have the data with a lot more variability or data that's less reliable, then we lean more on the spatiotemporal smoothing. So it's essentially a way of looking at the residuals of the model, the difference between the first stage model, well, not first stage model, but the spatiotemporal model that we fit, and the observed data points, and then fitting this kernel regression component on those residuals in order to produce improved estimates. However, when we do this kernel regression step, which is this is all done in a Bayesian framework, so we will fit the model, and it will follow data, but it does it with prior distributions and that sort of regularization, so that we don't overfit the data. Excuse me. But once we do that, then our uncertainty intervals tended to be too narrow. So we have this third final step, which is uncertainty calibration, which is a method that fits an optimizing function in order to scale the uncertainty intervals to guarantee that we have correct coverage of our prediction intervals. So this whole approach is what we call this one mod method to estimate all-cause mortality. And so that's this new method that we fit. Of course, there's a lot more details in the capstone paper, and I encourage you to read that to get more information about this. This is just a summary. So let's dive into the key results that we found in this round of the GBD 2023. One of the important findings that we reported is that life expectancy has generally returned to pre-pandemic levels in 2/3 of countries and territories. So when we compare life expectancy in 2023 versus 2019, about 2/3 of countries and territories in our analysis had returned to their pre-pandemic levels. This figure here shows for each super region, each GBD super region, the trajectory of life expectancy at birth from 2013 to 2023. And so we have, you see here, across pretty much all countries, we have this, or across all super regions, we have this drop in life expectancy due to the COVID-19 pandemic, and then subsequent recovery, which is differential across super regions. And of course, within super regions, this is differential across countries. But many locations have seen a recovery to pre-pandemic levels, which is very encouraging news that sort of on the global scale, a lot of countries are have recovered from the largest impacts of the pandemic. However, of course, this does mean that 1/3 of countries and territories still have not, by 2023, had not recovered to their life expectancy levels that were observed before the pandemic. So, of course, a lot more work continues to need to be done on this front in order to deal with the aftermath of the COVID-19 pandemic. When we dig down to age-specific mortality, there are some alarming trends across countries in North America and Eastern Europe that we've seen, notably among children and young adults. And so here we are showing some of those key results that were very surprising, very alarming at least. On the left here, we see deaths among or mortality among children aged 5 to 14 in the US and Canada. And we see from 1990 to about 2015, there's a decrease. And then that has leveled out and then even started to increase in recent years. And so this is a trend that was very, very alarming to see, and something that is indicative of some factors that really need to be addressed. Then if we look at mortality among those aged 15 to 24 in the Eastern European region, GBD region, and we also here included the United States and Canada as well, we see that there is also been an increase in mortality in these young adult ages across a number of countries here in this region. And when we look at the trajectories in particular, although it's a bit hard to see because the scale gets a bit small in recent years here, there are, of course, important factors here driving this that are important to dig into, and something that is against or different, at least from other regions across the world. And finally, when we look into sort of what the impacts, especially in sub-Saharan Africa, are when we think back about the new data that we've incorporated, data in ages 5 to 19, or sorry, 5 to 14, and also age-specific data for sibling histories, as well as health and demographic surveillance site data. We found that mortality among girls and women aged 15 to 29 years in sub-Saharan Africa was 61% greater than previously reported. And additionally, we found that this is across all time periods, on average, we found that mortality in ages 5 to 14 were about almost 90% higher than previously reported. And this is because the new data that we've incorporated have shown that the observed deaths, the observed mortality is higher than our previous methods were estimating by just using model-based estimates for these age groups. And so including this new data shows that while, of course, we're not saying that over time things are increasing, it's just the level of mortality is higher than we thought it previously was, based on this new data. And we can dig into this a little bit more as well. This here shows by GBD super region the percent difference in the in deaths in the under 5 age group, as well as the 5 to 14 age group. And here we see that that we have highlighted here. Deaths in the 5 to 14 age group are a lot higher across the years in sub-Saharan Africa. In early years in 1950, we also see higher deaths in these age groups across a lot of other super regions as well, because of other countries in these regions that rely on complete birth history data, especially. And then, of course, borrowing strength when we have data sparsity, because data is a lot more sparse back in time, closer to 1950. So we also see higher deaths there. And then we also see lower deaths in the under 5 age groups. And this also, of course, has some contribution to this is due to our updated population estimates for this round of the GBD. But the particular one result that we want to highlight is this higher number of deaths in sub-Saharan Africa across all time periods in the study. And then when we look at other ages, so if we look at the 15 to 34 age group, as well as the 50 plus age group, we see, at least in ages 15 to 34, we see a lot higher deaths in the sub-Saharan Africa super region. But another finding that we wanted to highlight as well is that in ages 50 and older, we're now estimating fewer deaths than previous. And that's because by incorporating this health and demographic surveillance site data, as well as this sort of overhaul of looking at household death recall data in sub-Saharan Africa, as well as across the globe, we found that in these data, the observed mortality rates and the age pattern of mortality seem to show lower mortality in these older age groups across sub-Saharan Africa. This is, of course, on average, but lower mortality than we had previously been estimating as well. And a lot of this is due to the fact that our previous methods that used these model life table systems that were imposing age distributions of mortality or age patterns of mortality across from higher income countries and imposing those onto these lower income countries seem to be not reflecting what the actual age patterns of mortality are in the data that we observe. And so when we use our new statistical modeling methods, we find these results of fewer deaths now in older ages in sub-Saharan Africa. So that is a bit of a flavor of the results for the capstone for the GBD 2023 on demographic estimates, particularly all-cause mortality. And yeah, I think now we are going to be going over the questions that have been submitted. So I will pass it over back to Sarah to facilitate the question and answer session.
Yes, thank you so much for that presentation. We are now happy to take questions. We have a few that have already come through on the question and answer tool, but if you would like to ask any more, please go ahead and put those in. And then if we are unable to answer any of your questions today, please do follow up with us at gbdsec@uw.edu, or if you want some more details. But to start things off, we have one. Does the new mortality model have an implication on life expectancy?
Yeah, that's a good question. So, I guess the short answer is yes, because the new mortality model is a way of estimating all-cause mortality rates by age and by sex. So maybe I should have described this in a little bit more detail, but essentially we process all of the data that we have on all-cause mortality, um, and we produce input data for the statistical model in the form of mortality rates by age and by sex. So we essentially have data on age and sex specific mortality for all of the GBD age groups. And then that data is what gets used in the model. And then from that, from our one mod statistical model, we produce estimates of age and sex specific mortality rates. And so those mortality rates are, of course, what are used to produce life tables and calculate life expectancy. And so our methods for calculating life expectancy haven't changed, but our estimation of age-specific mortality rates have changed. And so there will be an impact on life expectancy estimates because the all-cause mortality rates by age and by sex have changed. But in terms of our demographic methods for calculating life tables and calculating life expectancies, those remain the same as they have been in earlier rounds of GBD.
Thank you. And that question also asked a little bit for some guidance on finding the results. And so I'll follow up in the chat with some links to go to GBD results and then also our Viz tools to get that information. But thank you for the questions. We have another one asking about the results. Were there countries in 2023 where females had poor adjusted mortality rates and or life expectancy than males?
That's a good question. Off the top of my head, I'm not sure of any exact countries. There definitely were some, especially when we look at sort of the full spectrum or the full set of estimates from 1950 to 2023 across all locations. There are I do know that there were some cases of for example, of female life expectancy at birth being lower than male life expectancy at birth. A number of these situations would be in cases of mortality shocks, such as war and conflict. That tends to have a larger impact on male populations and female. Oh, sorry, not in terms of war and conflict. In terms of some HIV locations where in some locations females were more affected than males, and therefore on average when we look across the life course, I think life expectancy was in some of those cases were lower for females than males. And then yeah, in other cases there's a few, but in general, of course, female life expectancy on average does tend to be higher than males for biologic factors as well as other factors. But yeah, I mean, all of the GBD results are definitely publicly available, so that's something you can explore on your own. But if you're also curious about any particular instances or examples or locations, then I'm definitely happy to follow up and look at the results myself and see what there is.
Thank you. With the new methodology, will the time trends with previous years be compatible?
So yeah, so great question, and something that I definitely want to stress. For every time that we produce new estimates for the global burden of disease, so for GBD 2023, we completely reassess and re-estimate all of our estimates for the full time series. So for example, for all-cause mortality, all of our estimates from 1950 to 2023 are re-estimated using this new methodology. And so all of the time trends, all of our estimates that we publish for GBD 2023 are all consistent with each other. And so the time trends from 1950 to 2023 are all estimated from our single statistical model and are re-estimated, and therefore will be different from GBD, earlier GBD rounds like GBD 2021. So in that regard, all of the estimates from GBD 2023 are all consistent. But if you were to look at GBD 2021 results, like our previous round of estimates, and compare those to GBD 2023, then there would definitely be differences. And of course, a lot of the differences that I mentioned here. So when you're using any GBD results, always make sure that you're using the most recently released sets of results from the GBD, and only use estimates from within the same round of the GBD. So only use the GBD 2023 estimates for all use cases, and don't use some GBD 2021 and some GBD 2023 results, for example, because you'll have those differences.
Thank you. With the new modeling using separate age groups like 5 to 9 and 10 to 14 years, did you also expand to revise the list of causes of death or diseases with these age groups?
That's a good question. So the short answer is no, and the reasoning for that is because we have always produced estimates for these age groups. So previously we've always produced estimates for ages 5 to 9 and 10 to 14. It's just that we had been relying on estimates from our model life table system to inform the all-cause mortality in these age groups, as opposed to using data in these age groups and making sure that our estimates are consistent with that data. But all of this sort of innovation and these new data sources that we're using for complete birth histories and health and demographic surveillance sites, these are all new data that are incorporated into our model for all-cause mortality. And so we're producing these estimates of all-cause mortality, and then that is what is used in the GBD as sort of the all-encompassing estimate of deaths. And then we have our separate modeling for causes of death, which we have or had other webinars in this GBD in Focus series covering those methods for cause-specific mortality estimation. But those estimation, or the cause-specific mortality estimation, that still happens as it has. I mean, of course, there's additional innovations that have happened since the previous round of GBD in terms of cause-specific mortality estimation. But the estimation of cause-specific mortality is in that sense separate from all-cause mortality. And then once we have produced estimates of cause-specific mortality for all causes, then those cause-specific mortality estimates are then rescaled so that they all sum up to our estimates of all-cause mortality. And so basically, by including this new data for these new age groups for estimating all-cause mortality, it will affect the overall level of mortality in these age groups that the cause-specific mortality estimates have to scale to. But it doesn't actually impact what causes we can produce estimates for. Like, all of that data is still being used. We don't necessarily have new data. I mean, we do have new data on those cause-specific models because we always update new data for every round of the GBD. But these specific innovations are just for all-cause mortality. So there's no additional information from these all-cause mortality data sources on cause-specific mortality. So there's no changes to the list of causes that we can estimate in these age groups. Hopefully that makes sense.
Yes, thank you so much. I have a question about the use of HDSS data. So as they do not fully reflect respective countries, what value have they brought to GBD estimates?
Yeah, that's a really good question. And so for our our one mod model that we use to estimate these age specific mortality rates, um, it's you could think of it as, or especially like the first step, this spatiotemporal modeling step. Uh, what we do in that step is that we use covariates to inform mortality trends. We use all of the data that we possibly can. We have a nested spatial structure within subnational units, national units, regions, and super regions, and global. Um, and then we have correlations in these covariates across age groups, as well as time trend correlations across space. And it's a really flexible, essentially, you can think of it as like a general linear regression model. But in doing that, we can incorporate this health and demographic surveillance site data um, in a way that essentially treats that data as coming from its own location, um, and then say that that location itself is nested within whatever country it came from, which is then nested within the region and the super region and global. And so the data itself doesn't isn't directly included in our model as if it came from whatever country it came from. So that means that we're not overly imposing the patterns from that HDSS data onto that specific country, because like you said, it only comes from a very small subset of the population in that country. But by using this sort of nested structure and including this data in the model, it allows and including covariates that we have for that location, it allows us to use the levels and trends and especially the age correlations in that data, and use the spatiotemporal modeling with covariates to borrow strength from that data in an informative way to inform the estimates in the country that the HDSS site comes from, as well as through the region that it's in, the super region and global, and of course through that sort of spatial cascade, the borrowing strength, like borrowing strength from it is you are going to be producing estimates that are more similar at smaller scales, and then the effect of it will sort of dissipate as you get to larger and larger spatial scales. But we can use the covariate relationships, the age patterns, the time trends, and essentially use that to improve the estimation in countries and in countries across regions that are data sparse, that might not have a lot of data, especially on age patterns of mortality, to improve those estimates as we can. And this happens in an informative way through our regularization within the Bayesian model, which is of course is validated through cross validation and other model validation and selection metrics. So yeah, in short, that's how we can incorporate this data without overly relying on it to impose patterns in countries, that because it's not fully nationally representative.
Thank you. We have a question about the model life table. So which model life table are you using, or was there a new model to accommodate all countries?
Yeah, so like I mentioned, we are no longer using model life table systems at all. So for GBD 2023 is the first time in the GBD that we've stopped using any sort of model life table system. In GBD 2021 and earlier, we had the GBD had its own model life table system that it developed, which you can read about in earlier publications. Essentially, it had a large we created a large large database of empirically observed life tables. I think we had 10 to 15,000 empirically observed life tables in this database. And then we did a matching system, or a method of matching from this empirical life table to this database of empirical life tables, matching the like 110 or 100 closest life tables to the input parameters of child and adult mortality that we modeled. And then we essentially did a weighted average of these matched life tables, and then rescaled the age-specific mortality rates from the average of these matched life tables to then match the input data. But again, we don't use that anymore. Our method for GBD 2023 is to directly estimate the age-specific mortality rates from the input data that we process and use in the model, and then that will produce age-specific mortality rates for every country in the GBD, every country, year, age, sex, and then we can use standard demographic methods to create life tables from those age-specific mortality rates.
Thank you. And I think that we have gotten through most of our questions here, so please do continue to write in any questions that you have. And in the meantime, I think I'm going to ask you some broader questions, Austin. So were there any unexpected or outlier results in your work, and how did you account for them?
Yeah, that's a good question. And I think whenever we think of unexpected results, or whenever we think of results out of the norm, I think some of the results that I've presented in this presentation, I think in terms of especially the how much higher we're estimating mortality to be in sub-Saharan Africa and other low-income countries that rely on complete birth history data and sibling survival history data. I think that is a very surprising result. Going into the development of this new method, one of the drivers of doing this is that we had looked at what the observed mortality rates in these new in these data were. So looking at the complete birth history data and just empirically looking at what the observed mortality was in these data and comparing them to our estimates, and we found reasonably large discrepancies that led us to developing this new method. But it wasn't I don't think it was really at the scale, or we didn't appreciate the scale at how much higher the mortality actually was. And part of that is because of also our new method of directly modeling the age specific mortality data and using the age correlations that are observed. If data in ages 5 to 9 and 10 to 14 are estimated to be higher, then due to the correlated mortality rates across age, then that is going to lead to ages 15 to 19, 20 and 24, 25, 29, et cetera, also being higher. And that kind of has a larger, broader impact than just the mortality being higher in adolescent ages. And so I think the scale of that is one of the most surprising results that we found. Yeah, I think some other results that you can read about in the capstone publication as well, that I didn't quite touch on here. There are other regions across the globe beyond just the Eastern European region, where especially across some high-income countries, mortality in younger adult ages tend to be either flatlining or in some cases increasing. And we found that the narrative of quote unquote deaths of despair and and deaths from causes such as suicide, homicide, accidents, that sort of thing, tend to be um, uh, uh, increasing in a major way across a number of locations, which is an important finding to be aware of. But yeah, those are some of the important ones. But there's a lot more information in the capstone publication as well. So definitely recommend everyone to check that out.
Are there any assumptions for the one mod model?
Yes, that is a great question, and every statistical model is going to have assumptions, and so there are a number of assumptions that we sort of detail the caveats of in the capstone publication. Some of the important ones are that we have, I mean, the one mod model itself is only going to be as accurate as the input data that go into it. And so we have a lot of methods for processing the input data to get it into a form that is that we can fit the one mod model on. So for example, the sibling survival history data, we have methods where we take the mortality or the survey data on mortality of siblings, and that data has a lot of known biases in it, such as zero reporter bias. So if there's any sib ships that where all of the siblings have died, then there's no way of getting mortality information from those. So we have to come up with corrections and adjustments to account for these zero survivor sib ships. There's also recall bias in that data that we're adjusting for as well. And so some assumptions are that, that the data processing methods and the bias correction methods that we're using are accurate and reflecting the actual biases or correcting for the biases that that are present in that data. So that's definitely one of the big ones. We don't have any, because this of the non-parametric method of the non-parametric components of one mod is in particular in the kernel regression smoothing step, that is that's non-parametric, so we don't necessarily have distributional assumptions. And from the uncertainty calibration, we don't necessarily need to worry about the accuracy of the initial standard error estimations, because we're post adjusting the uncertainty intervals to account for that. But there are, I mean, we're fitting a model with covariates that have a lot of, we're relying on the strength of associations across covariates, which that assumption, I guess, is strong in some places that are data sparse. But again, it's the best we can do, and we strive to produce the most accurate estimates everywhere based on the data available, and try to produce estimates that are accurate across as possible across the globe, that can then be used and then of course improved with subsequent rounds of the GBD. So yeah, off the top of my head, I think those are some of the most important assumptions that we rely on. But yeah, I think there's a few more detailed in the capstone publication as well for additional information.
And I did put a link to the capstone publications in the chat as well. So please do go ahead and take a look. Maybe we'll take one or two more questions here before we finish up. This is another broader question for you. So if a practitioner were to apply the findings, what is the most important piece of context that they should keep in mind?
That is an interesting question for sure. It's the most important context that her practitioner should use or keep in mind when using results. I think that it's, I mean, it is important to know that, uh, I guess I'll say that it depends on what results you're using and uh, what what your particular use case is. So I think there's different caveats for using data in some locations versus other locations. Um, so it's a bit hard to answer that question, but in general, I think that you should be aware that there is, of course, uncertainty associated with all of our estimates, and we publish our uncertainty intervals, so you have a good idea of how much uncertainty we have that we're estimating with these models. But especially if you're using these estimates in places that are potentially data sparse and may not have reliable data, it's really important to know that these are estimates. They are the best estimates that we feel that we can produce, but there is going to be uncertainty. And if we don't have data or we don't have reliable data, then these estimates could potentially not reflect the truth. Um, and that's important in terms of uh, I guess qualifying any sort of use that you're going to have from these estimates. And of course, the estimates are only as good as the data. Because the estimates are only as good as the data we have, we always want to try to get as much data and more up-to-date data as possible. So if if you are using these estimates and if things seem to not match with potentially any data that you know of as an expert in your field, then it's really useful for you to check if specific data sources are being used in the GBD, and if they're not, then letting us know that so that we can uh, find this data that we may not have known about or not have extracted for the GBD, and then we can use that to improve our estimates in the future, because we are always improving our estimates. We're always collecting as much data and more data as possible as we can, and yeah, and we want to rely on our network of collaborators to improve our estimates in the future. So, there will be another round of the GBD coming out, and those estimates will then again be improved. And a lot of that depends on our collaborators being able to let us know if any data sources are available that we might be missing, and also if there's any results in general that might seem wrong or seem like they have any errors in them. Uh, because being able to have that additional contextual knowledge from others can allow us to continue to improve our results in the future. So that information is very useful to have as well.
Thank you so much. And with that, please do, as Dr. Schumacher just said, reach out to us if you have any thoughts or any insight into data that we could be including at gbdstack@uw.edu, or if there's any questions that come up from the presentation later on or that we weren't able to get to today. And with that, I think we're going to close for today. Thank you once again for joining us. The GBD would not be possible without the collaborator network. And we will be sharing a recording of this session with all collaborators on the collaborator portal as soon as possible. We also do have, again, these sessions coming up. So we have another one with Dr. Schumacher later this week with the same content. And then we also have one in 2 days on November 5th, non-fatal and risk factors session. And thank you once again to Dr. Schumacher, first and foremost, and thank you all to joining us this morning or today. And I hope you all have a wonderful rest of the day. Thank you.
Thanks, everyone. Have a good one.
Bye.